everyone. Welcome to our 98th briefing. Yesterday, we promised you that we were going to address the issue of home-based care. As you all remember, home-based care is an initiative that we recently launched, and there have been numerous questions, both from yourselves as media houses, but also from the public with regard to how is the program being rolled out, what is the criteria, and so today our briefing will focus heavily on home-based care. It is important to note that the ministry launched the home-based care isolation and care protocols on 10th June 2020. And Kenya is the only country in the region that is implementing this program as one of the case management strategies to combat coronavirus disease. The protocols that have been designed and that are in use in Kenya have been developed in line with the World Health Organization guidelines. The approach of home-based care was arrived at following extensive consultation with various stakeholders with the aim of relieving pressure from our healthcare systems. And this is in consideration that 78% of infected persons are asymptomatic or have mild symptoms which can be managed at home. These guidelines have been developed taking into consideration our local socioeconomic situation, and the guidelines have been translated into Kiswahili, and counties are urged to translate them into local languages. And it is important for Kenyans to note the process of development of these guidelines actually involved a lot of community participation. The Ministry of Health officials and experts were able to engage with the different members in the communities, the village elders, our community-based organizations, to be able to get guidance as to how Kenya can best adopt a home-based care approach, particularly for asymptomatic cases. So, ladies and gentlemen, the positive cases that we are now reporting, as you all know, are a result of community transmission. And we are aware now that the disease is firmly within our urban and rural settings. And as of yesterday, 40 out of 47 counties had reported cases of COVID-19, which amounts to about 85% of counties in the country. Nairobi is leading with 2,428 cases, followed with Mombasa with 1,304 cases, followed by Busia and Kajiado, which have had many cases in terms of cross-border truck drivers. And we have the numbers at 361 and 179 cases respectively. The other cases that we've had 155 from Kiambu, Uasin Gishu has had 66, Migori 59, Kilifi 52, Kwale 51, Machakos 44, Nakuru 32, Garissa 25, Taita Taveta 25, Kisumu 20, Mandera 18, Wajir 17. And this information is available for you, articulating the cumulative caseload per county in the country. Mombasa and Nairobi city counties have had the highest infection rate of COVID-19. And we've been able to look at this and define that Mombasa has an attack rate of about 107, whereas Nairobi has about an attack rate of 55. And these statistics are important because it tells us that the risk of transmission, the risk of you getting COVID-19 is higher in Mombasa compared to Nairobi counties. And again, we're working to ensure that we are actually able to define risk per county as we continue going forward. And therefore, from all these statistics, it becomes less tenable to isolate confirmed COVID-19 patients in hospital-based treatment. And therefore, as we roll out the home-based care protocol, it's important to note that we are focusing on our high-burden counties, particularly those that have a high attack rate. And as highlighted, that is Mombasa and Nairobi. We are working with community health workers and volunteers to ensure that we educate our households and our caregivers in this program. And the training, as I've said, is targeted particularly in the high-risk counties, and this is where we will start the rollout of the home-based care protocol. In terms of training, some of you might wonder, what exactly is this training focused on? And the idea is that we're able to go to households, we're able to get in touch with the family members, take them through what it means to be eligible for home-based care. So not every single Kenyan is eligible for home-based care. There's actually a criteria that determines who would be able to be enrolled into the home-based care program. We then review the feasibility. How are you able to actually ensure that the home-based care program is working in your household? And then what are the procedures that need to be in place? How do we monitor? How shall the healthcare worker be able to engage with you to ensure that we're looking after you and your family and ensuring that you're adhering to the home-based care protocols? It is important to know that our training goes further to empower individuals and households with basic knowledge, skills, and competencies to be able to enable them to function as caregivers of COVID-19 patients. And in addition to this, we are utilizing our other community-based structures, such as the Nyumba Kumi initiative and the community health committees, to ensure that there is actually compliance of these protocols. For eligibility, eligible patients for this program are usually assessed by a healthcare worker. And as mentioned and highlighted yesterday by the DG, the first criteria is that you have to be COVID-19 positive. Number two, you have to be asymptomatic. That means you do not have or you do not present with the symptoms ama zile dalili za COVID-19. Or if you have any symptoms, then you have very mild symptoms and you have no underlying medical conditions. Asymptomatic patients are therefore put in this program. And in terms of discharge, how does the discharge criteria look like? Discharge happens at 14 days from the date of the first COVID-19 test. And this must be in line with ensuring that at the point of discharge, this patient does not have any symptoms. So you've been at home for 14 days. We did your first test. It was COVID-19 positive. We've come back at 14 days. We've done a subsequent test, and you're negative, and you have no symptoms. If we have mild symptomatic patients, these ones will only be discharged if they have not developed fever for at least 72 hours. And this is important. As highlighted earlier, we are focusing home-based care on patients who do not have symptoms or those who have mild symptoms. If you have mild symptoms and one of the symptoms you have is fever, raised temperature, then it would mean that you're only discharged from home-based care upon you not recording a fever for 72 hours, and that you're also not on any medication that would be helping suppress your fever. Now, in the event that your condition deteriorates, because we appreciate that, yes, you could be asymptomatic and you're enrolled in the home-based care protocol, and perhaps at some point your condition deteriorates, what actions can you take as a caregiver? One, you call the 719 number. You could also do the text message, and you could also contact your designated healthcare worker, and a process of admission would then ensue from that point. Now, on to our COVID-19 situation. In terms of statistics today, we tested 4,859 samples, of which 254 people tested positive for the virus. Therefore, this brings to total our country caseload to 5,206. The total number of tests conducted thus far cumulatively from the beginning is 151,396,000 tests. All the positive cases are Kenyans, and we have 186 of them as male and 68 as female. And it's important to note the trend continues. Our male patients, our Kenyans, our fathers and brothers continue to be the ones who are highly afflicted with COVID-19. With regard to the 254 positive cases, in terms of county distribution, we have Nairobi having 127, Mombasa having 36, Migori 29, Kajiado 22, Kiambu 12, Busia 9, Uasin Gishu 5, Murang'a 3, Machakos and Kilifi have registered 2 cases, and we have 1 case from Nakuru, Siaya, Taita Taveta, Garissa, Isiolo, Kakamega, and Kisii, all having 1 case. We do also have distribution in terms of sub-county, and I'll highlight some of the key ones. I won't go through to all of them. In Nairobi, from the 127 cases, we now have 32 cases from Westlands. In terms of Dagoretti North, we have 18. Lang'ata has 16. Kamukunji has 14. And Embakasi East has 12. In terms of Mombasa, we have 36 cases from Mombasa, of which 11 are from Mvita. Jomvu has 8. Kisauni and Likoni both have 5. And in Migori, the area that has the most caseload would be from Suna East. In Kiambu, of the 12 cases that we've mentioned, most 4 each are from Thika and Kiambu town. In Busia, in terms of the 9 cases, we have 7 from Teso South, In Wasingishu, the 5 cases, we have 3 from Ainabakoi, and Tabo and Keses have 1 case each. In Machakos, we have a case in Athi River and 1 in Matungulu. And in Kilifi, we have 2 cases in Rabai and 1 in Kilifi South. We will provide you with this disaggregated case list. What we are noticing is that now the disease is really spreading across all the different wards within the country in terms of the counties that are afflicted. Yesterday, there was a question with regards to the testing in the country in terms of the numbers tested positive out of the cumulative number tested, and we've also provided this information for you today. Again, I won't go through it all, but if we can touch on a few counties. With regards to Busia, in terms of the samples that were collected in the last 24 hours, from Busia, we have about 9 cases that tested positive out of a total of 353. So what this means is that in the last 24 hours, we have a positivity rate in Busia of 3%. I'm going to try and pick out perhaps what we'd have in Nairobi. In Nairobi, we have 127 cases, of which in terms of samples collected, we did 2,484 in Nairobi County. Again, giving us 5% positivity rates in Nairobi. And it is important, and I'm sure we'll ask the DG to expound on what it means in terms of this positivity rate. We have it differing. We have counties such as Kajiado in the last 24 hours having a positivity rate of 15%. I'm sure the question will be, what does that mean for Kajiado? We have counties like Kakamega with 1 positive case out of 5 samples collected, so 20% positivity. We shall highlight to you perhaps during the question and answer session what this means. Ideally, it is a statistic that is useful for us. However, it needs to also be interpreted with caution and in view of looking at other statistical figures, but I'm sure the DG will talk on that. On a positive note, we have discharged 41 patients from various hospitals, bringing the tally of recoveries to 1,823. And our gratitude goes to the healthcare workers for the good work. However, sadly, we've lost 2 more patients to the disease, bringing a total number of those who've succumbed to 130. And our thoughts and prayers are with the families and friends of those who have departed. And as we conclude, we would like to thank our healthcare workers, and in particular our community health volunteers, who are supervising the home-based isolation care program in conjunction with experts in the Ministry of Health, and we thank them for their commitment and dedication. And the success of this program really is pegged on them and the adherence of these protocols. And as highlighted, the protocols are available at the Ministry of Health's website. If you Google www.health.go.ke, you'll be able to see these protocols there, articulating all the measures that need to be taken, how you're able to actually enroll into the program, what the eligibility criteria is, how monitoring and supervision is conducted within the program, how discharge looks like, and what follow-up would also look like upon discharge. And finally, let us all remember that our first line of defense to beat this virus remains the adherence to the containment measures. And as we all know, these are washing our hands with soap and running water, maintaining physical distance, and wearing of masks when we're in public places. Thank you. Questions?
Hi, my name is Graham Kajila from The Standard. My question is about the home-based care guidelines. Do you have any criteria that could make you stop, like a patient who is at home, is on home-based care, and then you see how they're behaving and you decide that this patient is supposed to go back to hospital? That is apart from developing any serious symptoms. Because I'm asking this because a family member probably could get the disease, and will the family member still be handled as a home-based care patient? And the other question is, how does the number of samples actually mirror the number of people who have been tested? Because I understand you say that we can get samples from the nose and the throat. Those could be 2 samples from 1 patient. So how many patients exactly, or people exactly, have we tested?
Purity Museo from KBC. My first question, would you kindly elaborate on why Mombasa County has a higher attack rate as compared to other counties? Does it have anything to do with the containment measures? And then you said that 78% of patients are asymptomatic, and WHO again says that these patients cannot transmit this virus. We have over 5,000 cases right now. Who exactly is transmitting this virus? Is it the 12% that is asymptomatic? On the fatalities, lastly, kindly an elaboration on the 130 cases that we have so far. How many lost their lives while receiving treatment, let's say, under critical care, and how many lost their lives while at home?
Naoma Sampao from NTV. My question is about home-based care. What is the criteria of following up to ensure that the process is effective? Again, South Africa has started testing vaccines. I would like to know what is Kenya's contribution to that?
Okay, I'm Haemba from Ebro TV. My question is, maybe with more than 40 counties so far affected, it actually implies that almost the entire country is affected with this pandemic. Maybe my question is, as Kenya as a country that is actually embedded, that actually embraces the social cultural beliefs, what is the way forward maybe for the cultural beliefs of some of the communities in the country which actually maybe practices certain beliefs in certain periods within the country? The way forward.
Thank you. My name is Ben Kirira from K24 TV. And my first question is on cases of home care patients. We have had claims of home care patients leaving their houses without protection. Are you in a position to confirm or deny this? My second question is on teenage pregnancies. Last briefing yesterday, you mentioned that in a survey conducted last year, you found out that there are 4,000 teenage pregnancies. Also, in a recent briefing, Dr. Patrick Amol mentioned that there are 400,000 teenage pregnancies according to a demographic health survey in 2019. Can you kindly elaborate on that? And lastly, of the 4,859 cases tested in the last 24 hours, I would like to know where do you place these people as they await their results? Do they go home, or do you have a certain isolation facility you keep them as they await their results? Thank you.
Thank you. Thank you all for your questions. I'll start with Graham's question with regards to the criteria for stopping home-based care approach, and I think there have been numerous questions that are tied to this. We have another one regarding the monitoring of home-based care. We have Ben asking whether patients, are walking around in terms of home-based care and how we're monitoring them. And we also have I think those are the main questions touching on home-based care. So yes, indeed, like we said, our protocols, one, were really developed in conjunction with community leaders and with Kenyans themselves. And the team within the ministry was able to engage along with partners. What does it mean to actually have home-based care set up in Kenya, in Nairobi, in Mombasa? How will that work? And what we did is that there was actually a pilot exercise that was undertaken. And through the pilot exercise, we were able to come up with a criteria. And as highlighted, and the DG will expound on this, there's an assessment of who can actually be eligible to home-based care. And part of this eligibility, beyond being positive, is really the feasibility or the ability of you to be able to undertake home-based care. Now, breach of home-based care is actually a breach, one, on your own, health and that of your community, and that we would take seriously. And so patients who are on this home-based care are actually under follow-up, and it's a follow-up process that is tiered. So you have the community supporting and participating in terms of ensuring that there's friendly supervision and enforcement of that. We have looked and tried to define mechanisms of how we can actually identify the households in a particular estate or in a particular village who would be undergoing home-based care. Of course, noting that we do not want to create a situation of stigma when it comes to those who are undergoing home-based care. So it's important to note that this is a program one. It has undergone a pilot evaluation. It is something that we are monitoring as we continue deploying it. It is a program that we are taking extreme caution in terms of deploying it and ensuring that we are actually able to ensure that there is that monitoring and evaluation. And I'll ask the DG upon conclusion here that he elaborates further on this program in terms of the questions asked. There's a very good question regarding the samples. In terms of when we say you have 1,000 and something samples taken, are we taking into account the nasal swab and the oral swab? Yes, so for you to actually be able to undergo, a testing, procedure in terms of COVID-19, you do require those two swabs and samples taken. And remember, as we've highlighted in the past, there are patients who actually would have consumption of, more than one set of swabs and oropharyngeal swabs. But again, I'll ask the DG to highlight on this in terms of sample collection. And if, at the end of the day, I think the question is, when we say we've done, 4,000 tests, are we saying those were 4,000 swabs, oral swabs, 4,000 nasal swabs? And the answer to that would be yes and no, depending, because there are patients who end up having 2, 3, swabbing procedures done at the same time. And remember, it's important, even as you take the swab, you actually conduct the procedure well to be able to get the sample that you're after. And so sometimes there could be discarding of one sample or one swab. With regards to the question in terms of the disease having, affected most counties, yes, it's true. Right now we do have a record of 40, and that's why we've been trying to now share our positivity rate and our attack rates in terms of county distribution. And we've always said there's already community transmission within the country, and if we don't continue adhering to our measures, then the idea is that at the end of it all 47 counties might actually be afflicted. And we've said in the coming days, remember, perhaps we've not reached our peak yet. So our numbers shall continue rising, and this is a situation that we will see evolving. There's a question regarding, from Purity Museo, in terms of why Mombasa, why Nairobi, what is the difference there? And again, an issue that is under study, and it is a function of multiple variables when you look at that. There are certain, perhaps, should I say, variables when it comes to adherence of measures. For Nairobi, we all know one of the reasons why we are one of the high burden counties is because we had our import cases coming here, and that's the same situation in terms of Mombasa. At the beginning of this pandemic, importation started within Nairobi and Mombasa. And it's important to note also, perhaps because of the high mobility, these are rural, these are urban towns that have a lot of activity, high mobility, a lot of contact between individuals, and these are factors that have contributed to those counties having the highest attack rate. Perhaps going forward, the question becomes, how will this attack rate evolve? And could this attack rate actually be a measure of each and every one of us when it comes to containment measures? Because remember, we've told you it's a measure of risk. So if you're in Mombasa and Nairobi, then it is expected that you actually are more, on guard in terms of ensuring that you're adhering to the measures. There is a question on asymptomatic cases, again from Purity Museo. Again, we are trying to study the disease, and I do remember actually at the beginning, of this pandemic, we felt that perhaps caution was necessary in terms of asymptomatic cases. A lot of studies have been undertaken to be able to find out at what point in the disease is an individual actually most, transmittable. At what point of the disease are you shedding the most virus, meaning you're dangerous in that phase of the disease. And right now, the data varies in terms of this. We had indication of, from day 1 to 5. 5 is the day to watch, 5 to 10. This keeps changing in terms of new emerging evidence. But what we want to say is we want to still take caution. Even if you're asymptomatic and you're positive in terms of COVID-19, you still have to adhere to the measures, and you still have to, observe your hand washing, observe your social distancing. There is a question in terms of fatality. Again, the DG will expound on this. What I do know is, at least from yesterday and today, some of the fatalities we have are actually patients who are diabetic and hypertensive. And that's why, as emphasized in past cases, that lifestyle diseases remain to be one of the impediments in terms of the coronavirus disease. And we really, really need to ensure, if you're diabetic, if you're hypertensive, if you're pre-diabetic, ensure that you're actually putting in place measures to protect yourself. And these measures have been highlighted: a healthy diet, good nutrition, ensuring that you're able to, exercise, and then most importantly, that you're actually taking your medication. So that remains important. And DG, perhaps Purity the DG will highlight for you in terms of our most recent fatalities, if those happened at home or in the hospital. We had a very interesting question regarding culture. And perhaps just to expand further, I'm not sure what we were leading on to, but the main thing remains in terms of public health. When you're trying to deploy a public health intervention, the social norms and the culture of a community become very important, because again, as we all know, the community is at the front line in terms of fighting this disease, you and I. And so, of course, it becomes important as we roll out, one, our communication, to take into consideration what societal, cultural norms exist. I am aware that different communities have gone ahead and perhaps put suspensions into some of the activities that usually take place. I did come across, in terms of the media, issues to do with circumcision and the seasons. And perhaps what I'd do is applaud those communities who've taken that bold move to put a pause on some of the cultural practices that we have, so that we can be able to protect, ourselves and the country. And that can be applauded, is applaudable and remarkable that communities can make that move. And this is happening across the world. I'm sure you've seen for Hajj, there's been suspensions in terms of the number of people who can go for for the pilgrimage. And so we are expecting to see modifications in how we really undertake our social and cultural norms. And this is welcome, especially now when community is what matters. So perhaps DG, expanding a bit more on the home-based care protocol and the testing, as well as the fatalities. Yeah.
Thank you, Madam CS. Let me start with a question on the fatalities. Yes, of the 130 cases that we have reported dead, majority of these people have been people who are over 60 years, and majority of them have been people with other coexisting medical conditions. Initially, especially in Mombasa, in the early stages, we recorded a number of home-based deaths. But because of intensified interventions and behavior change communication led by the Mombasa team, we are recording fewer and fewer community-based deaths. The deaths we report today actually occurred in facilities, one at Kenyatta University Teaching Referral Hospital, and the other one occurred at Avenue Hospital, same as what happened yesterday. So majority of our people are actually going to seek services in a health facility, and for those who have lost their lives, majority of them have lost their lives at the facility level. In terms of the home-based care criteria, of course, number one is that you must have a positive COVID-19 test confirmed on laboratory. You must be asymptomatic, as Madam CS said, and you must not have any coexisting medical condition. We need to review where you live so that you can be able to have space that you can be able to stay during the period of care. This space must be well ventilated, so it must have appropriate aeration. You must have a caregiver who can be able to support you and whom you can be able to train to do very basic things like issue of infection prevention control measures. Of course, for home-based care, you require some PPEs, basic PPEs. You may require a thermometer or the community health volunteer. And toilet facilities, and there should be no other vulnerable person living here. And this therefore means that we place a very high premium on home-based care on the individual and the caregiver to be able to undertake all these interventions. Of course, breach of any home-based care guidelines means we quickly move you to institutional isolation facility. As concerning the testing, yes, we take 2 samples, one deep from your throat through your nose, then the other one through your throat. And all these are treated as one. So even if you take 2 specimens, we treat that as one specimen for assessment. Those are not 2 tests. Because the one deep inside your throat is more sensitive in picking the viral particle than the one through your throat. So what we are trying to do is just to ensure that in case you are positive, we don't miss anything. Something that I forgot about home-based care is that monitoring will continue on a day-to-day basis, and we will also have what we call a symptomatology triage, where each and every day the community health volunteer or the healthcare worker will come to ask you certain questions regarding your progress, like whether you have developed a cough in the process of your disease, whether you have any difficulty in breathing, or any other symptoms which may require that now you move from home-based care to institutional isolation. There was a question on the teenage pregnancies. Yes, the correct figure. On an annual basis from the Kenya Demographical Survey of 2019, the number is about 400,000 girls aged 10 to 19 years who get pregnant. But the figure that came from Machakos on further interrogation is actually untrue, because we have gone to our database to mine the figures, and the figure for Machakos as at now is slightly just over 1,000. And as Madam CAS articulated yesterday, when teenagers come for antenatal clinics, this is based on a case-by-case visit rather than a longitudinal profile. So sometimes you may interpret each and every visit like a different teenager coming for assessment. So usually what happens is that total number of ANC cases, antenatal care cases, the teenage pregnancies will just range about a third of that. So if you have 3,000 total antenatal care clients coming in a facility in 1 month, then teenagers could work to just around 1,000. There was another question about vaccine. Yes, Kenya is a member of the global health arena and will play our role appropriately as the vaccine studies continue. Of course, development of vaccines is a process, it's not an event. You need a bit of time, you require lots of resources, and we have credible institutions, including our own KEMRI, which will be part and parcel of this process at a due time when the right procedures and protocols have been addressed. I think that is all that came my way. Thank you.